Welcome to the Interventional Glaucoma Podcast, brought to you by Elios. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field.
My name is Verena Prokosch. I'm a glaucoma consultant at the University Eye Hospital in Cologne, and I'm here with Nishani Amerasinghe. She's a full-time consultant ophthalmic surgeon based at the University Hospital of Southampton in the UK, as well, specialized for the treatment of glaucoma and cataract surgery. And with this, I really warmly welcome you to the Interventional Glaucoma Podcast series. And I will be your host today, and we will discuss in this episode integrating glaucoma surgery techniques such as excimer trabeculostomy into your phaco routine. We'll explore together how, on a very practical level, you can do that seamlessly in different types of practices, and critically examine the impact of interventional glaucoma procedures such as Elios on our patients and within our practices. I'm looking forward to a kind of learning from you, Nishani, and kind of just even for us as experts, exchanging ideas and views, especially throughout different countries and borders, because I bet you the system is a bit different in Germany as opposed to the UK. But I do believe that actually nowadays for our patient, as opposed to like 50 years ago when there was only traps and tubes, interventional glaucoma approaches are the key, basically, to treat patients earlier, individualized, and kind of take them off the drops and be interventional in our approaches. And this is, I bet, due to different factors. First of all, the adherence of drops is really poor in patients. 60% of the patients don't even take their drops. The ocular surface is a problem because all the drops, they kind of really kind of molest the ocular surface. That's another problem, basically, as well. Nishani, I'm really curious to hear from you, basically. How did you implement interventional glaucoma approaches in general, and especially the Elios phaco procedure into your practice? What were your challenges, and what is important to look at, which patients to treat?
Yeah, thank you, Verena. I think I completely agree with you that interventional glaucoma is the way ahead. You know, we need to deliver the best for our patients, individualized care. So therefore, the idea of interventional glaucoma and introducing minimally invasive glaucoma surgery is an easy concept to take on, because we want to help patients basically reduce their drop usage. So you're not relying on them to be compliant and adherent. You want to improve their ocular surface. If you need to do any further surgery, secondary filtration surgery, you want that ocular surface to be as good as possible. It's been shown that minimally invasive glaucoma surgery is cost effective. So it's a win-win. And so when you're bringing those arguments to your new procedures committee, like we have in the UK when we bring any new procedure in, those are all very good arguments to use to provide the best care for your patients. When we brought in the procedure of Elios, we already had a couple of minimally invasive glaucoma surgery techniques. So we were already quite used to dealing with our committee and showing the evidence behind the surgery, and also the aims and outcomes of the Elios technique. So it was easier from that point of view. The fact it was a laser technique seemed to cause us a little bit more problems, because we had to go through laser safety and training of the nurses. But again, it wasn't a very big deal. So because it's got good results and good safety data, it was easy to bring in.
Yes, and I completely agree, because we had started with a different MIGS phaco devices even before Elios became very popular. But maybe you agree, from my experience, Elios is maybe one of the easiest amongst them, right? Because with stenting, sometimes it's really tricky. You kind of the stand is kind of, I don't know, it doesn't stick or it's difficult to place. Whereas with Elios, especially compared to SLT, you know how to target the trabecular meshwork.
Yes.
You have the bubbles. It's kind of the same, isn't it?
Yeah, I agree. I've always said out of all of the minimally invasive glaucoma procedures, Elios is the easiest.
Yes.
That goes with the proviso that you have very good angle visualizations. So if you are starting off as this as being your first technique in angle surgery, I think the most important thing is that you are very comfortable with surgical gonioscopy and gonioergonomics. Yes. Once you've visualize that angle well and you know exactly where the structures are, the Elios is very easy to deliver.
Yes. But I mean, going back to what you said, I do agree that actually gonioscopy is the key, and knowing how to do it properly, right? And looking at the patients maybe even the day before, and have a good idea of what gonioscopy looks like in this patient.
Yes.
I think especially if you begin with, I think it's good to kind of fish out the easy ones with the wide angle, right? And of course, as I said, like even whilst doing surgery, it's good to make yourself familiar with how to do it. Gonioscopy on the table, right? And even the pressure in the eye makes a difference. Don't have it too low, because then you get corneal folds, and right, it makes your visualization really poor. If the eye is too hard, then might be difficult as well, because you don't get the blood reflux and stuff like that. So I think these are maybe things we should point out, which makes the surgery itself easier if you stick to that, right?
Oh, yeah, definitely. So I think practicing surgical gonioscopy, I think you've got to first of all, obviously, be very familiar with the angle structures anyway. So obviously normal gonioscopy at the slit lamp and understand the angle structures. When you're doing surgical gonioscopy, obviously it's slightly different because you're not getting that corneal wedge. So you've got to know where Schlemm's canal is to understand where your structures are. But as you say, techniques like allowing for blood reflux into Schlemm's canal, so you know where it is, or even if you're having real problems with a blonde angle, using vision blue to dye the canal can help you identify the structures, and then it's so much easier to carry out the surgery. Also, as you say, you've got to be at the right pressure, because otherwise you'll get corneal folds or stria, which also obscure your view. And all of this takes a little bit of practice. So I do say to my trainees before they go ahead with doing angle surgery, that when they're doing cataract surgery, just get used to having a look at the angle, getting the head in the right position, getting the microscope in the right position, being comfortable themselves, and just looking at the angle so that they're in practice before they carry out angle surgery properly.
Yes, for sure. I mean, that's really good. And of course, then the next step is positioning of the patient as well, right? That you kind of position the patient so you've got a really good view onto the trabecular meshwork of this patient. I think that makes a difference. You can do it in local, right? And you can do it in GA. Might have to bend the head.
I mean, I do most of my patients under local, either topical or with subtenons, and then it's far more easy to position the head. Obviously, when you're positioning the head, ask the patient to turn their head, make sure they haven't got any neck problems or anything like that. Get them to turn the head. You can then do the slight positioning after that. And then position the microscope. And again, you can either set that up beforehand. I've got pre-settings on my microscope. The surgical workflow, it doesn't disrupt it at all, I would say. You know, once your nurses are happy to and confident setting up the machine, which doesn't, is not very much training for that either. But once they're confident doing that, they're ready as soon as you finished the phaco, because I do the phaco first before I go ahead with the Elios technique. And then it's a matter of minutes, isn't it, really, before you finish?
Yeah. It's pretty straightforward and really quick. And learning curve, of course, we discussed it already. I think, like, if you are familiar with doing MIGS and gonioscopy, then learning the Elios technique, I would say it doesn't take much really. I mean, you don't even really, I wouldn't say you don't need to learn it. Of course, you need some introduction, how to use it, especially the nurses, how to kind of calibrate the laser, right? But otherwise, it's pretty easy, and the procedure itself, it takes a couple of seconds.
I completely agree. It's a very easy technique to introduce and to carry out once you know how to look at the angle properly and identify the structures. You also get good feedback because you have the bubbles forming. You know that you've delivered the right amount of energy in the right place, and then you can go on to deliver the other 9 shots. So it doesn't really take very long.
Yeah. We talked about the challenges. You mentioned them as well, of introducing it maybe into practice, right? As you said before, we had the kind of the challenge of the scrub nurses, because they want everything to be hygienic, and then you have to be careful. You have to teach them with a probe, because you need to calibrate it. So it goes into the device and then back on the table, of course, all sterile, but yeah, I think they maybe need some teaching how to handle this properly. But I would say this is the only challenge we had. Of course, that was it. Otherwise, we didn't face challenges as such, if I think.
No, I agree. I think it does take a little bit more scrub nurse training than some of the other procedures.
Exactly. You just have
I think device. That's more to do with the confidence of the scrub team, rather than it's actually difficult to do. But after a couple of sessions, it really, everyone's
they're fine. It's just like handing it over. They were a bit like, okay, how do I do it to make sure it's not kind of touching anything here? But I mean, that was fine, because for them, of course, it's easier if they just give you a device, then it's
exactly
you don't need them, right?
I think that's that's really their confidence, giving them the confidence to be happy to use it. It's not actually technically difficult for them to calibrate the device, and the backup that we got from our surgical specialist, the Elios surgical specialist, was great. They did some sort of teaching sessions before the theatre, the actual first theatre list, and then they were there through the first few theatre lists, just to give the confidence to the scrub team that they can do it, and they had people there to ask questions. So there's a really good backup team as well, from the Elios surgical specialists as well.
And one question, I mean, in terms of implementing to who, I mean, you see your patients in clinic, and then you kind of offer it if they have cataract, or which patients do you choose?
Yes, so I think managing patient expectations is a really, really big one that develops with your relationship with the patients. So I think, if they've got cataract surgery and glaucoma, I really do believe that you have to have a discussion about Phaco plus a minimally invasive glaucoma procedure. I think it's a missed opportunity if you don't. Now, the outcome from that will be different for different patients. So it may be that you're taking them off a drop. You're not changing their target IOP, but you're hopefully taking them off a drop, whether that's to give them a better compliance, better ocular surface. We may be thinking about surgery in the future, but this might give us just a little bit of time to plan that surgery, or even negate it, or carry it out further down the line. It's discussing that with the patient, so that both of you have a surgical outcome and a surgical expectation defined, so that when you have carried out the procedure, you get a good result. So for some patients, that might be off a drop and therefore have a better ocular surface. For another, it might be a better target IOP.
Yes, I do agree. And actually, we should pick, of course, the mild to moderate glaucoma patients who have cataract anyhow, I would say, and they need the cataract surgery. I mean, that's my patients I pick for it. And who would benefit from better ocular surface, for sure. I think that's a completely underestimated thing, because if you look at the patients, sometimes you can already see that they're glaucoma patients by just walking in, because the eyelid is so red, and the ocular surface, of course, doesn't look any better. And and they have glare and all these things because of the eye drops, right? If you've been taking them for so many years. So
and when you get them off the drops, they're so grateful.
They're super happy.
It's life-changing for them. It really is.
Exactly.
You know, even if you don't get them off all their drops, you reduce it by 1 or 2. Yes. If you're improving that ocular surface, they're really happy patients.
That makes a big difference to them. And I think I kind of nowadays openly discuss it, like basically that it's not about drops. It's basically thinking about getting them off the drops as well. Because they don't feel their glaucoma, but they feel the side effects of the drop. And of course, you need to consider that they take their drops, but the ocular surface is so dry, so they need to take lubricants even more. So they have to take drops, let's say 6-7 times a day, because they need the lubricants as well to kind of wear off the effect of the drops, right? And then it's a vicious circle in a way. So
their life gets ruled by drops, and if you can reduce that, then their quality of life is so much better. And I think we underestimate this because we don't ask about it as much. But you really see it when they've been brought off the drops, how grateful they are.
Yes. Because everyone is just looking at the pressure all the time. It's still very pressure focused. Even the patient just asks for the pressure. How was the pressure? But no one asks how's the ocular surface. I mean, but I think that's going to change, especially if there's alternative treatments, interventional treatments and stuff like that. And quality of life, of course, even the EGS ages ago said it's the main goal, right? To improve quality of life. Everyone looks at IOP all the time and not at quality of life, although it's so much more important in the end than the IOP.
I completely agree.
In the end, we treat patients and not the IOP. I think
exactly. And we see these patients all the time, we see them throughout their life. We have a relationship with them, and if we're the nasty doctor that changed their lives because we gave them drops, they were asymptomatic before they got referred to us. If we can change that management plan and intervention, then our patients will be happier, our relationships will be better. There is so many benefits to it. I think interventional glaucoma is the way ahead, maybe not relying so much on drops being first line or stacking drops or them being the main treatment. If they could be sort of the bridging treatment between different interventions, so that the patients don't have to be compliant with treatments, or also that if they do need secondary surgery later on, it's either delayed, or when it does happen, we've got better ocular surface to have better outcomes. I think this is the way that glaucoma management should be.
Yeah, I completely agree. I think everyone should know it, but like unfortunately, it's still like drops and drops and drops, and that's the treatment. That's in many heads of patients. But I think the easy bit is like, especially if we talk about the MIGS, like they need a phaco anyhow, and they see better after surgery. So I think it's an easy way to just combine it, to just how is it called in English? I mean, in Germany, we have it hits 2 birds with 1 stone, right?
Yes, we have the same, 2 birds with 1 stone. Yeah, exactly. And I think, it's always thought of that it's easier just to stack on another drop and, stack the medications up. But actually, if you look at something like the Elios procedure, it doesn't add much to your surgical time. The patient's already going to be in surgery to have their cataract done. It's a win-win if you carry out an Elios procedure on the patient.
As said, I guess you should at least suggest it to the patients. And I mean, you even mentioned missed opportunity, right? If you don't, and I do completely agree, because it changes their life. And I have patients who have had the surgery in one eye, and then they ask for the other one straight away because it's so much better. And you can see it, because the eye that's operated, it doesn't have these long eyelashes and the deep set eye and the pigmentation anymore, because of all the prostaglandins they take. Some side effects are unfortunately reversible as well. So I think that makes a difference to them, even how they look. We shouldn't forget about looks as well, although it's a minor thing and we are not talking about cosmetic outcomes, but it makes a difference to them, because I mean, everyone looks at the eyes all the time and it's in the face. So if a patient comes in with loads of redness in the eyes and side effects, I think it is time to at least ask the patient, do you really tolerate the drops, or does it matter to you? And many say yes, but no one has ever asked me yet.
Yes, agree.
Right? Because it was about drops, and treating the IOP, but it's not only about that, right?
Exactly.
And I think we both agreed that actually it is really easy to implement, and it doesn't add much time to surgery, as said.
No, it's an easy learning curve. We have the results, the outcomes and safety data. So that's always the thing that you need to give to committees or management so that you can bring it in. We've got the data that shows that it's cost effective. So again, that helps with implementing it. The actual procedure itself, as we discussed, is easy to do once you've learnt your angle visualization. If you're used to doing minimally invasive glaucoma surgery, then actually Elios will be the easiest procedure that you do out of your angle surgeries. If this is the first minimally invasive procedure that you're doing, then once you've mastered the technique of surgical gonioscopy, again, you'll find it very easy. It's a very short learning curve. Going on training your nurses, I think, is probably the biggest barrier that we've come across, both of us, giving them the confidence, but actually with the backup of the surgical specialists from the company, the training is done very well, and they're very well supported. So that's not such a big obstacle in the long term.
Well, I think what we could summarize, Nishani, is that we could kind of invite everyone to just to kind of implement it in their practices, especially as cataract surgeons as well.
Mm-hmm.
And I would say good cataract surgeon who is familiar with the gonioscopic view and knows glaucoma maybe should implement it, or should at least offer it to the patients as well. And don't hesitate to kind of try it out, because it is not difficult, I would say, and you'll surely manage, and it's for the benefit of the patient, and you have an extra kind of tool how you can treat their glaucoma as well, and potentially improve quality of life and get them off the drops.
Yes. So I think, definitely any glaucoma patient that's having cataract surgery should have the discussion about having a MIGS procedure as well.
Yeah. Well, with this, I thank you for tuning into this episode of Interventional Glaucoma. I thank you for the discussion, Nishani, a lot. I really enjoyed it.
Yeah, it was lovely.
Talking from country to country, I think there's the same view, right? And
definitely.
Yeah, it was so good. I mean, I learned a lot as well, and it's always good to kind of exchange.
Yes, definitely. It was lovely to exchange the ideas. Thank you.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more details on this episode and to read the show notes, visit eliosvision.com/OUS/podcast. To learn more about Elios and contact us, click the link in the description. The Elios system Bausch and Lomb is manufactured by MLase GmbH and by WEINERT Fibre Optics GmbH. Elios is CE marked for use in adult patients with glaucoma and is currently under investigational use in the US as part of an ongoing IDE study by the FDA. The ExTra 2 Laser Class 4 has the brand name Elios. The ExTra 2 is equivalent to ExTra and AIDA devices. Please refer to the full disclaimer in the show notes.